right, good afternoon, everyone. So my name is Carl Grover, and today I'll be giving my final thesis presentation on the probabilistic descriptions of patient anatomy for radiotherapy treatment planning. My supervisor for this project was Martin Ebert. Oh dear, why is it not moving? Oh, there we go. So for radiotherapy treatment planning, an essential tool that's used for plan evaluation and the prediction of treatment outcomes is the dose volume histogram. This histogram is used to describe the radiation dose that's delivered to the tissue volume as a fractional volume of how much is actually receiving each dose. And from this, you're able to extract certain dose parameters and everything that can be used for plan evaluation or optimization. One of the major caveats of this representation is that we end up taking high resolution imaging information and reduce it down to a binary representation of the structure volume via delineation, losing a lot of this spatial information that was provided originally. So some of the disadvantages of this include that we have a spatial degeneracy, where if you look to the right, where we have these two cases, though because they have the same frequency of doses across the volume, they would have equivalent DVHs put out. However, the DVH then fails to consider that there may be certain areas of increased radiosensitivity within the actual organ, and so one of these plans may actually be more favorable than the other, despite having the same metric being used for optimization and calculation. Additionally, these definitions rely on the assumption that we're able to accurately define the patient's anatomy down to the level of image voxels. However, in reality, we actually have a number of geometric uncertainties that exist in this, including things to do with actual treatment delivery uncertainties, limits in image specificity, and so on. So one of these major geometric uncertainties that's actually considered is the interobserver variability. And what this actually is the fact that if two observers delineate a patient's anatomy, they end up producing two distinct definitions of the same anatomical structure, imparting their own personal bias. If you look at the figure on the right here, we can see that each of these contours have slight variations, and what ends up resulting is multiple different treatment plans, and it calls into question which of these actually fully represents the true patient's anatomy. So this ends up being one of the most significant sources in uncertainty within the entirety of radiotherapy, and has multiple factors affecting it, including the experience and familiarity of the clinician, the education they've received, guidelines and trainings that's in place, and so on. So in an effort to kind of account for these geometric uncertainties, one of the more modern methods that has been discussed is probabilistic approaches to volume definition, where rather than using this discrete binary definition of it, the added probability structure is implemented into the actual definitions to incorporate the uncertainties related to that definition. This has been examined over a number of different studies with different takes on it. Some of these include some of the initial findings from Shasharina, where with these, she ends up having these different shells of likelihood as to if they contain tumorous volumes, and pretty much uses that for optimization. Beauty ends up developing on this, where instead of a normal margin expansion to get a CTV, what they actually do is implement in a model for the uncertainty related to subclinical disease extent to have a more probabilistic representation and characterization of the actual likelihoods of subclinical disease outside of the gross tumor volume. And finally, this has also been explored in particular with organs at risk, particularly Odegaard's using this to account for interfraction motion, and kind of having this situation where different voxels have weightings based on how much agreement there is over multiple different times that the anatomy has been imaged and segmented to kind of put increased weighting. So within the literature that's currently put out on this topic, there are a few holes. One of the major ones is the fact that there's currently no direct implementation of the interobserver variability into the definitions of probabilistic structure. A lot of the focus has been around tumor likelihood and models regarding that. In addition, with the exception of models that incorporate inter and intrafractional motion, the current models are exclusive to target definition and lack any real considerations of organ at risk. As such, we get into what my project is. So the overall aim of my project was to develop a model for probabilistic descriptions of patient anatomy, which can directly incorporate into it the interobserver variability within the volume definitions of CTV and rectums for prostate cancer patients. Additionally, this project also assesses the feasibility of using a deformable image registration method in order to propagate a large number of contours over for structure creation and consider a much wider range of contours and get higher resolutions. This research ultimately serves as an exploration for the potential considerations of clinical implementation, and also the beginnings of work towards the implementing of these probabilistic structures into creating a more robust model for deriving treatment optimization parameters such as the DVH, tumor control probability, and so on. In terms of the overall significance that this has, an estimated 48.3% of cancer patients in Australia end up receiving radiotherapy at least once throughout the course of their treatment. And within this, 20 to 25% of those patients end up reporting adverse physical consequences of the treatment, which negatively impact their overall quality of life. Improving the quality of life outcomes following treatment with more robust methods for estimating treatment outcomes is an essential step towards improving treatment quality and ensuring that we're not causing more harm to the patient than we are by actually treating. As conventional approaches rely on simplified binary representations of the region of interest, the ideal pathway for the development of a more robust model is to better incorporate geometric uncertainties into these definitions of patient anatomy. To begin with the project, we end up working with two different data sets. So the first one is an atlas set, which comprises of 5 exemplar patients taken from a larger pelvic CT data set that was from Calvary Mater Newcastle Hospital over in New South Wales. For each of these exemplar patients, there are 10 observer contours for both the CTV and the rectum, and the overall file format is using the Neuroimaging Infographics Technology Initiative, or NIFTY files. As well, we have a test population set that we'll be considering, which is taken as a 254 patient subset of the larger CHIP trial dataset, CHIP standing for conventional versus hyperfractional high dose intensity modulated radiotherapy for prostate cancer trial. Within this dataset, this included CT data images, physical combined doses that they were going to be receiving, as well as manual segmentations of the anatomy. As well, there are 3 different treatment schedules that are considered, which will come into later play when we start to look at some DVH analysis and actually separating these. In terms of the code that was produced for this, 64 Python functions were written over the course of this entire project and were used for various things for performing computations, data processing, calculating results, including the formulations that are developed over this, just having these available. Unless otherwise specified, all data and results that are derived throughout this project were utilizing novel code that was written for the purpose of this project and is also adaptable for if anyone would look to further implement this or want to develop on it. It is all made available. In addition to the base Python toolkit that it provides, additional packages were included, including Pandas, NumPy, NearBabel, SupplyDK, and so on, just to obviously build the toolkit that was used for this. So though I don't have the time to properly go into this today, I wanted to give a bit of an introduction on the deformable image registration process that was used. So deformable image registration itself is an iterative optimization process where it produces a deformable vector field that's capable of transforming a reference image, or in this case, the Atlas case CTs, to best match towards a target image, in this case, the test population CTs. So in performing this, for both the test population pre-processing that needed to occur to actually perform this and the deformable image registration process itself, this was used from adapting a Atlas-based auto-segmentation pipeline that was originally produced by Angel Kennedy. So the ultimate reason that we are doing this is because we want to propagate contours from the Atlas test cases over to the test case anatomy and derive similarity metrics for them. This will be so that we have a larger consideration of contours that we're going to be considering for constructing our probabilistic volumes. And yeah, in terms of what we actually use for similarity metrics, to compare the image similarity, we use the normalized cross correlation. And for target comparison of similarity, volumetric similarity, we use the dissimilarity coefficient. So the overall result that we end up having is after we do all of this propagation, we end up having 50 propagated contours for each of the test patients' anatomies, including normalized cross-correlation information for the registrations that were performed, and dissimilarity coefficients for how each propagated structure matches to the target structure. In terms of the actual formulation that was used for creating probabilistic structures, it was based on the interfractional motion probability distributions that were produced by Odegaard's for. So for this, what these actually breaks down to is basically that each voxel value ends up representing the percentage of contours that agree that a given voxel should be included within the definition of the region of interest. While the equation is provided here, just for a bit of diagrammatic simplification, so for each of these voxels that are considered, we end up taking a weighted sum by multiplying by the weightings of each of the respective coordinates in all of our nifty structure files, taking a weighted sum, dividing by that to normalize it back so it goes from the range of 0 to 1. And what we end up having is these probabilistic structures which represent different degrees of certainty and how much agreement is actually in that voxel being represented in the true organ. In addition, to actually create this, we also need to include the affine information from the original Nifty structures, which is basically how this structure relates to the world coordinates so that it's comparable to other files such as dose files or the CT information themselves, and they'll be combined and calculated to make these final probabilistic structures. This is done with two different parameter sets. So whenever we're working with the atlas structures, we are considering 10 contours that we're propagating across, well, 10 that we're using to construct these probabilistic structures, and each of them will have a simple weighting of 1. Whereas when we're working with the test population structures where we have the total 50 contours that we're actually considering, each of them is going to be receiving a weighting value that's equal to the normalized cross-correlation value that they got for how their atlas CT that they come from, how similar that was to the test patients after the registration process. An important thing to note is that we do rely on a very big assumption with this, is that the fact that there's no quantifiable difference in accuracy for any one contour's ability to represent the theoretical ground truth. We can't say that this person has a better representation or a better understanding of it. There's no quantifiable means. So as such, this means that equal weighting will be given to contours derived from the same atlas patient. In terms of actually analyzing the probabilistic structures that are created, we do it in a threefold process. So first of all, we have a look at how the deformable image registration actually impacts the contour variability. Does this introduce a significant additional variability that needs to be considered with further work with this pipeline? Secondly, we have a look at how the propagated contour population for each of the test patients compares to their actual anatomy. And this is done by comparing to the manual contours that were provided for these test patients. And this is done within 3 different measures. So this is done by comparing the dissimilarity coefficient of how well the propagated contours match to the test patient anatomy, having a look at the actual volume of the propagated contours compared to the test patient contours, and as well having a look at the DVH and doing a comparison there. Finally, we also have a look at the manual versus propagated contours and seeing how they do in the probabilistic structures that are created to figure out if using the probabilistic contours is able to achieve an equivalent accuracy to those that are produced from using manual contours. Finally, and the final process of this project was to kind of develop a probabilistic representation of the DVH. So this method is able to directly incorporate probabilistic structures of the organs into DVH analysis. How this is done is that pretty much at each voxel within the probabilistic structure, there is a dose that it's expected to receive based on the combined dose file, and also there's a certainty that it will receive based on how it's defined within its probabilistic structure. And what we end up doing is we combine these to create these set of 2 tuples that is basically a combination of the dose and certainty tied together. From there, we're able to separate the doses that are received by the total probabilistic volume into decile subgroups based on the certainties. So grouping together all the voxels that had certainties between 0 and 0.1 and so on in a 0.1 voxel value increments. The result of this is that we end up being able to create these stacked histograms where each of the DVH bins have additional information that reflects the proportion of certain certainty values within those voxels within those bins. Overall, this is more of a generalized analysis of potential trends and doesn't really provide a quantifiable analysis. It's more just to have a look at the potential of this and how we could work with this in the future. So to begin, as we look at the exemplar probabilistic structures, so these are the structures created for the atlas patients, we actually find that the overall structure of these compare pretty well to the previous models that have been created for probabilistic structures. As we can see in the bottom here, we have Shosharina's one where she had the different shells, and where as you moved out from this center of mass of the organ, you'd actually have decreasing certainty. Similarly here we have the CTV, and here is the rectum. And as we can see, this very bright area reflects where there's a very high agreement across all observers that this is a region that belongs, which is in line with previous models. And as you extend out to the outer edges of the organs, there starts to be greater variability, especially because the actual process is the outlining of the edges. And so small variations there can lead to an increase in variability of these. To assess the overall variability of these contours that are used to construct, we also did a calculation of the dissimilarity coefficients between all of the contours that were used to construct each probabilistic structure. And what we ended up finding is that the mean dissimilarity coefficient for CTV ended up being about 0.83, while for the rectum it ended up being 0.81. So as we move on to this, in order to assess the impact of deformable image registration on the interobserver variability, we have a look at it in two different ways. First, as we mentioned, we had the dissimilarity coefficient that we calculated between all of the structures within each atlas patient. And we have a look at how this compares before and after we do the propagation step, just to see how much the variability actually changes in there. Starting with the CTV, when we ended up doing this, we ended up finding that the decrease in dissimilarity coefficient had a statistically significant difference based on a Welsh t-test. This value for the t-score ended up being 9.36. So this ends up reflecting that there is actually a significant increase in the variability due to deformable image registration that is in addition to the interobserver variability that was always there. This can be attributed mostly to the fact that the deformable vector fields that are actually used end up removing the relationship between neighboring pixels. So what ends up happening is you can kind of have this expansion or a contraction and this deformable motion, and it actually introduces a greater variability compared to what is seen there. Additionally, we also had a look at this in terms of the fractional volumes. Of particular focus is the fractional volume of complete agreement. So we have a look here, and this represents the fraction of the total probabilistic volume that has 100% agreement across all observers. Everyone included those voxels within their definition. And as you can see here, there was a decrease in this, and overall the mean decrease in fractional volume data across this entire graph ended up being up 7.99%. By comparison, having a look at the rectum, the differences were a little bit smaller. In particular, the t-test score ended up being 2.21, which, though a bit smaller and everything and not as drastically large, this still reflects a significant increase that is statistically significant. And similarly, we find that there is still that reduction in the fraction that has complete agreement across them. And yeah, so that's comparable reasons just because of that deformable vector field. In terms of looking at the propagated contour population and how well they actually represent the test patient anatomy, starting with the dissimilarity coefficients, we end up finding that the mean dissimilarity coefficient of propagated contours compared to the test patient anatomy ends up being 6.41 for, well, 0.641 for the CT dissimilarity coefficients and 0.568 for rectum. This ends up reflecting a 19.67% decrease in dissimilarity coefficients compared to the overall variability among contours in each atlas case of, for the CT, and also for the rectum, we end up having this decrease of 28.82%. So in general, when we consider dissimilarity coefficients, an acceptable one, just as a general consensus, could be considered about a 0.8 or a 0.85. But this can vary depending on your treatments and such. Some people tote that you need a 0.9 and such, but yeah. So overall, we find that there is quite a significant decrease compared to how the contours compare within themselves and how they're meant to compare to the atlas patient anatomy, or the test patient anatomy. Additionally, when we have a look at the volume analysis, we find that for increasing test patient contour volumes, there's actually a deviation in how well the mean propagated contour volume is being equivalent to those during the process. So what this actually reflects is that during the registration process, volumes are not being expanded enough to actually be able to match the volume that's expected of the test patient anatomy. In particular, the statistics are given here with a 21.74% fraction of test cases actually lying within the 95% confidence interval of the contour populations. And this is a lot higher, mostly due to the variance that exists between the volumes that were considered. And for the rectum, this is a lot smaller and very drastic of 3.54%. So it begins to call into question whether these volumes are actually very well representative of the target patient anatomy. As well, we start to have a look at the DVH for these, and the best way that I can describe this is kind of to perform this DVH analysis. What we ended up doing is we compared the dose volume histogram for the manually segmented structures for the actual test patient volume, and we compared the mean DVH values that is achieved across all of the propagated contours. As you can see, especially on this figure, we also have this faded dotted line, and this actually represents the band of the 95% confidence interval. So as we do a comparison to here, this plot is mostly done for the sake of being able to more easily understand it. We find that in total, 61.4% of CTV dose bins DVH values actually fall within there. This higher value is mostly attributed to the fact of the general structure of CTV dose volume histograms where we kind of have this very steady, because of most of the volume, the doses prescribed being very close to the prescribed dose volume, like you've got a very high dose of near minimum. So because of that, you end up having a very consistent there, and that can be reflected in the very low population variability across this region. Whereas you end up seeing very significant deviations as you start to consider here. For rectum, only about 22% of these dose bins actually end up lining up on average. And yeah, it ends up having a much broader range of population variability across it. And whereas for the CTV, we ended up finding that actually there's usually a drop in there's usually a drop in the mean propagated contour DVHs very early, whereas there wasn't really a distinguishable trend among the rectum results. So as we start to have a look here, we do a comparison of kind of the manual. So these manual contours used for the Atlas case and propagated contours used for the test case. This is for the test patient. As you can begin to notice, we actually see that there's a very consistent there's a much higher resolution in the probabilistic structure. And that's because we're considering almost 5 times the number of contours, as well as we're having the additional weighting based on the normalized cross-correlation information that was provided. Of note, even though we ended up having smaller volumes as shown in the previous example of preparing the propagated contours, they actually end up having a pretty good coverage, and that's mostly due to where the exemplar contours originate. So the exemplar patients that were previously used with Angel's pipeline and were selected because they could provide a good enough variability so that when performing automated segmentation, they could very nicely do it with a very small amount of patient data being considered. So because of this, even though they have smaller volumes, they're actually spread enough to where they're actually able to give a good coverage of the total volume that would be considered a part of it. In terms of the actual variability between contours that are constructing, we end up finding that the dissimilarity coefficients for CTV and rectum end up decreasing when we consider the contours that are used to construct propagated test case anatomy. This is primarily because of the fact that because we have the small volumes and also there's enough variance so that they can achieve very good coverage, we end up having this very small volume. So there's actually a very low amount that actually overlaps and has high agreement across all of these contours, as can be reflected by a comparison to here where we have much larger regions of high certainty, we end up having it smaller. This is similarly kind of summarized in these plots, which again is comparing those fractional volumes. And the main ones that we kind of care about is when we have a look comparing how propagated contours have, we end up finding that there's an increase in the fraction of cases that have very low certainty, below 20% certainty voxel values. We find that that actually ends up increasing by 0.346 for CTV and 0.365 for rectums. So there's a very vast, a much bigger proportion of the overall probabilistic volume is actually being considered of low certainty and low agreement across everyone. As well, we end up noticing, especially from this graph, that there's very drastic drops in the amount of volume that's considered to have full agreement across everyone. And this begins to call into question as to whether the propagated method is actually ideal for it compared to manual contours that are created. Having said this, however, when you consider the resolution that is able to be achieved with propagated contours, as you can see, there's a lot more data points that are being able to consider, and you can get a lot more specific with the actual probabilistic, like the certainty values that are achievable. That's because of the increased number of contours. If we were to want to achieve the same level of resolution for manual contours, we would need 50 contours for that. And overall, if we're going to look for clinical implementation at a point, it's not ideal to really ask that of 50 clinicians. It's just too much of a workload burden on them, including time as well. Finally, as well, I'll touch on just a little bit of information about the probabilistic DVHs that were produced. So these are 2 examples that were given, and as we can see, the distributions are able to show, it's able to present different distributions for the certainty levels of voxels that comprise the total probabilistic volume within the DVH information. In particular, we'll have potential to find trends where, as we can see, particularly for this rectum, we find that from doses of about 20 gray down to 30, we have majority of the high certainty and high agreement voxels within the probabilistic definition falling within that range. So what this could possibly lead to is future optimization. We may end up developing new treatment parameters and objective functions that are related to the favorable trends that we want to see in the probabilistic DVH values. In addition, we may also start to consider DVHs at different certainty thresholds. So removing all points in this that have certainties below 30% and considering how the DVH actually looks from that volume that's been contracted and is thresholded. As well, just for the next graph, we'll also note that there's actually a very high fractional, because of the very high fractional volume of low value voxels, we end up seeing that these values are actually very highly distributed across the entirety of the dose bins. And this actually ends up pulling down, as we'll see in these next functions, where the mean certainty that ends up getting achieved ends up being no higher than it doesn't even get higher than 0.5. And that's mostly just because of those very low distributed across there. So if we seek to improve that, we may actually find that this would be better representative, and with improved probabilistic volumes being created through propagation methods, we may actually see different trends. In terms of the trends we do see, however, we end up finding that the mean certainty for CTV information is proportional to the frequency of voxels within each of the dose bins. In particular, kind of the outlier case in this, I don't have too much time, but I'll simply say that this outlier here of the secondary peak was mostly due to a couple of outlier cases where the broadness of their actual DVH plots end up being too large compared to the rest of them. And that was mostly just a formatting error on my end. There's improvements that can be made to kind of move that out. I don't have too much time to talk about that in as much detail as I would like to. But one of the important things that I can mention is the fact that the dose of max certainty ends up being slightly greater than the actual prescribed dose, which maps to the peak frequency of the 57, 60, and 74 race schedules here. In terms of the rectum, we end up finding that there's an increased certainty, mean certainty across the dose bins between the second and third maximum frequency of the plots on the left. In particular, the max mean certainty ends up occurring at doses that are a few gray below this third maxima that ends up occurring here. Additionally, we find that there's a very sharp fall off in the mean certainties as we go past the actual prescribed dose that is given. And a particular clinical interest would be the high dose region where the rectal wall is in very close proximity of CTV. We want to have very good characterization of there and how certain we are with the voxels that are around that region, mostly because, that's where we're most at risk of delivering a very high dose. All right, so in terms of the conclusions that were drawn, the method for incorporating multiple observer contours into probabilistic structures achieved expected trends to probability distributions that were seen in the previously developed models with that kind of central, that center of mass with a higher probability and then extending outwards a decrease in the certainty. Contours that were propagated by using deformable image registration and the resulting probabilistic structures for the test population were subject to additional uncertainty and were therefore ill-representative of the overall inter-observer variability compared to how manual contours were. However, as you mentioned, for clinical implementation, we might actually want to be leaning more towards the automatic contouring and propagation techniques, mostly due to the demanding workload of getting equivalent number of contours manually defined to achieve the resolution that we actually managed to achieve in there. In addition, the production of the novel DVH representation that encoded probabilistic information within the population trends was derived, and the potential clinical benefit of over the standard DVH volumes was kind of described because we have that additional extractable information from these plots to allow for possible planning optimization methods. In terms of the future work that this could lead to, this would include looking to implement additional geometric uncertainties in the overall definition. Obviously, if we want to consider this as a clinical kind of an entirely new framework, we obviously need to implement a lot more geometric uncertainties into this definition. As well as this, having more detailed weightings of individual doses, which will be able to overcome the current assumption. So if we had a means of kind of being able to quantify each individual contour and how accurate they are to the test, the true anatomy of the patient, we could have a lot more resolution and a lot more detail in our created probabilistic maps. As well, we will want to probably look to improve the deformable Ebert registration method that was used for improved accuracy. Otherwise, we could consider alternative models that were used. There was a couple that I don't have the time to talk about too much, but yeah, there was that. Also consideration of automatic segmentation methods such as machine learning for the propagation and creation of multiple contours. And as well, in the overall goal, that it unfortunately did not extend to the overall scale of this ended up being too wide, and it was beyond the scope, but working towards the development of NTCP predictions for probabilistic structures would be very favorable, with one potential that has been considered being random effect modeling using Bayesian inference, which I don't have the time to get into here, unfortunately. In terms of my acknowledgements, I would like to give a big thanks to my supervisor, Martin, for his support and as a point of contact throughout this research, especially to Angel Kennedy for providing the necessary script and teachings on how to properly apply them and how I might want to consider adapting them for the purpose of my project, to Pejman for his work as the program chair for the medical physics group at UWA and his teachings throughout my master's. Nathaniel Barry especially I'd like to give because he did provide a lot of assistance in terms of the functionality of PyDPy and learning how to use that, which was one of the scripts for Python. And finally, I'd just like to give a big thank you to the University of Western Australia medical physics research community for the regular feedback that they were able to provide through weekly updates. It was really good, and it was a pleasure, honestly. There's my references, and thank you very much. Is there any questions?
Brilliant. Thanks so much, Carl. Any questions from Carl?
Was grand, thanks, Carl.
Thank you.
Yeah, I got a few questions, but like being your supervisor, maybe if there's someone else has a question, it might be good.
Yeah, of course.
Is there any questions on Martin's question? Yes. Okay, Martin, you can keep.
Yep. Martin, it might be better to just ask you a question. Yeah.
I can jump in with a question if you want.
Absolutely.
Can you hear me?
Yep, I can hear you.
Yeah, cool. Yeah, thanks for the presentation, Kyle. It was really great. I just wanted to maybe if I could get you to expand a little bit on what you think the potential would be for incorporating sort of like deep learning, machine learning stuff into the future.
Yeah, of course. So one of the major considerations with it is when we're working with this, obviously because the current method was to kind of incorporate that interobserver variability, while when we're considering kind of the deep learning or automatic contour regeneration, there would then be the potential to kind of adapt the overall what uncertainties we're actually considering with them. So versus where this considered the interobserver variability and the differences between different observer contours, there would be the potential of maybe running through a deep learning method and everything and producing multiple possible contours and kind of using that to represent as a kind of larger summary of the results of that and reflect the actual uncertainty that's related to those kind of deep learning and auto segmentation methods. Because yeah, although they do help with reducing the interobserver variability that does exist and they have their benefit just in terms of time, you do start to introduce those added uncertainties within those definitions. They have their own intrinsic ones. So there would kind of be that potential to where it could actually be developed and used there. Plus, they might be able to just produce a bit better and higher regions of increased like fractions of high certainty compared to what was achievable with the deformable image registration process, where yeah, we had that very low region of agreement compared to the larger fraction of more low certainty regions.
Yeah, great. Thanks, Kyle. I think I was just thinking about the sort of applications of this, and one of the things that I was thinking was that you could probably even train one of these models on the probabilistic contours themselves, right? So you sort of train them on those contours either by just applying like a threshold, right? So you want to include above a certain percentage weighting, say 80% of observers, include that contour in their delineations. Then you could train a model on that. And also the output from the deep learning model is probabilistic by nature anyway. So you could sort of incorporate that into things as well. Yeah.
Yeah, absolutely. And that's actually one of the benefits of Bayesian inference, is that you're actually able to get that probabilistic information out of the model. So even though the potential from developing from these of using a deep learning model to potentially then perform that NTCP prediction based on kind of, considering these regions of certainties and such. And I can only imagine the potentials. It's not really in my field of expertise, unfortunately, but I can only imagine with what it can provide of where it could go in the future with it, adaptation and inclusion of it within this project.
Yeah, definitely. Thanks, Carl.
No problem.
Can I go now, maybe? So I guess one of the things I originally thought we could use this for would be to get better estimates of parameters for the toxicity models. So if we now go back to the trial data set, normally people rely on the clinician's outline as a way of deriving the DVH information to get the estimate of toxicity. So perhaps just explain a little bit more how you'd think this could be used in that way to look at the trial data and perhaps overcome that bias of the individual clinician.
Absolutely. Yeah, so definitely, because we're kind of considering the DVH, obviously you're relying on a single binary contour that precisely defines. For one, you're kind of, though maybe not entirely directly, you're providing a little bit more spatial information in that. So there is potential that in those regions there are of particular concern, like particularly we might want to consider like NTCP prediction, where we're specifically worried about the dose that's received to the rectal wall that's in close proximity to the CTV. Just by having that additional uncertainty in there, I wouldn't be able to give complete details past, there was talks and everything about the idea of using this Bayesian inference, where you kind of you go off of a basic single contour and then adapt your beliefs on what the DVH may actually be by including the additional probabilistic information about how accurately do we actually know that this voxel is being considered based on a wider pool of individuals and how they would actually define it. So I'm not too sure if that's honestly answered your question, but yeah, there's definitely potential kind of just the intrinsic factor that we're considering an added probabilistic structure and how we may be able to actually include that and call into question how accurate the actual definition that within this dose volume histogram, particularly I talked about kind of with these, where you could even start to strip back and say, okay, well, I actually want to have a look at with the region that we are very certain with. So say the threshold of that they need to be above 60% accuracy, and seeing with how much we actually know, how important is this in the actual NTCP calculation, and kind of providing a specific weighting and optimization that could improve overall in the kind of NTCP calculation that you could give.
Yep. Another question. So we used that observer set that we had, the 10 outline observer set. And I guess there's a bit of an assumption there that represents a population of observers.
Yeah, of course.
But there might be an outlier or two, and who knows? Just from your observation of the observer outlines, do you think there were any outliers, and would there have been perhaps an advantage to removing them?
Yes, actually. So with the plot that I actually provided, I was specifically including this one just in case I got the chance. So as we can see here, especially with this rectum definition, we actually had, I believe that's only a single observer who's actually defined for this slice that it actually extends further up. And unfortunately, this is only taken from a single sagittal slice. So unfortunately, I couldn't really get an animation going to do a slide through and show exactly how that varies as we go through all of the slices and everything. But even just considering there, we start to see that, there's a single observer who, particularly in that kind of towards the superior region of the patient, they have that very drastic comparison to the other ones. And sure, the weighting is going to provide it, but when we're working with 10 patients, we're still saying that's about 10% likelihood, compared to if we had a larger amount of observer contours that we're considering, that could be closer to about 1% maybe. So yeah, we're kind of working with very small amounts of contours from specific observers, but yeah, kind of the demand it would require for having that many, it starts to come into question. But I do think that that would be a potential outlier for whichever observer had delineated that one and had that additional region at the top there.
Yep, that's good.
Yeah.
All right, thanks, Scott.
Yeah. Yeah.
So Kyle, I have a question. This is really good work. Thanks. Imagine if instead of the data sets you have in prostate cancer, you have the same data set but in head and neck.
Yeah.
What was your expectation of your auto segmentation if you had those data sets?
Oh, okay. I'll be honest, I do not, unfortunately, because of this, a lot of my focus has kind of been around the prostate and kind of those pelvic cancers. So I don't think I'd be able to give a proper answer to that, to how it might vary. But I think especially with there, because of the head and neck and the kind of regions that we're considering, I'm sure that, especially with this pipeline that Angel created, was specifically for pelvic cancers and everything. I imagine that you would need to consider an entirely different one. And there was actually a equivalent deformable image registration process that was actually used for head and neck cancers. And for those, the actual accuracy of that dissimilarity coefficient compared to here, where we got about 0.64 for the dissimilarity of how these propagated compared. Within there, they ended up achieving, they had the gold standard that you needed to hit 0.9. So obviously with there, there are a lot more requiring that, hey, we need a lot more accuracy in these. So yeah, at that point, we'll probably have to consider an alternative model to work with that, possibly specifically the one that paper worked with. But yeah, I imagine that with those, we might actually get increased actual comparison, especially because Angel's original pipeline actually functioned through wanting to use as small of an atlas set as possible to produce acceptable auto contouring. So, you know, as I mentioned, even though there was that very low region of agreement, it had good coverage because that was specifically constructed so that those patients were able to kind of give enough variability that when you constructed the automatic segmentation, it provided good coverage of them based on that. So yeah, I feel like I may have tangented a little bit there, but yeah, kind of that's the hope of, I imagine that it would be probably a lot better of a, would want to consider a much more robust one that's specifically built for head and neck cancers, and expected that they would probably achieve a lot better of dissimilarity coefficients there.
That's good. Thanks very much. Any other questions from Carl? No question? If there is no other questions, thanks very much, Carl. Well done.
Yep, thank you very much.
Good one, Carl.
Stop recording.
Yep.